So I've got 3 objectives today. It's impossible. Just try and touch on 3 simple points, and we'll keep this fairly quick. VATS pulmonary resection has lower morbidity and mortality than thoracotomy. There's some very strong data to support this. That VATS and robotic procedures appear to have similar outcomes, and that VATS pulmonary resection is much less expensive than robotic surgery. So first, we heard from Dr. Fernandez yesterday, but we, in the Society of Thoracic Surgeons, have made some nice risk-adjusted models looking at pulmonary resection. And when you just look at the patient baseline characteristics, we'll skip right here, then we look at approach. For all the pulmonary resections, only about 62% are being done minimally invasive. Just keep that in mind, it's important. And then we look at the predictors of our outcomes, both morbidity, mortality, and our composite outcome. It's a complicated slide, but to blow it up at the bottom, you have a significant increased risk with thoracotomy for both morbidity and mortality. It's almost a 50% increase for complications, and it's an 87% increase for death. Dr. McKenna, who's here with us today, showed all this back in 2006, that thoracoscopic lobectomy could be done very safely. This was on a series of patients accrued from 1992 to 2004, that the short-term results were very good with an under 1% mortality. That's better than what we see in the Society of Thoracic Surgeons with a very acceptable complication rate. Note that he was much more liberal in his definition of complications than we are in the STS. And then also very good long-term outcomes. Very impressive to have a large series by a small group of surgeons and to keep track of these long-term outcomes. We should all learn from this. So then we tried to make a composite model to look at our lobectomy performance by participants of the database. And again, we saw the same kind of thing. The operative mortality is low, 1.5%. And we all recognize now, based on the data, that thoracoscopic resections have improved outcomes. So very hard to make that a true quality measure, as there's not prospective randomized data to support it. We're not ever going to get prospective randomized data to look at it because people don't have equipoise. But we have made it kind of a quality measure that we show on our website. So for those of you participating in the public reporting effort, and for those of you who are just STS participants, you'll see that minimally invasive lobectomy for clinical stage 1 lung cancer now appears on your biannual reports. And it looks like this. This is actually our data from WashU. Overall, we're doing about 77% of our resections in a minimally invasive way. This includes both robotic and thoracoscopic. All right, and now we're going to skip to the second part. Use and outcomes of minimally invasive lobectomy for stage 1 non-small cell lung cancer in the National Cancer Database. This came out of Duke from Mark Berry. And they tried to do a nice propensity match study which looked at robotic versus thoracoscopic surgery. And if you look at all their outcomes, but particularly short-term outcomes, no difference in 30-day mortality, 30-day readmission, or hospital length of stay. There's a second study which actually looked at data from the STS. Senior author was Mark Block. Comparison of VATS and robotic approaches for clinical stages 1 and 2 non-small cell lung cancer. Mess it up. Good. And then the same kind of thing is shown here. We look at post-operative morbidity, and if you look on the far right, it's pretty simple. All the p-values, not one of them is statistically significant. And then we'll cut to the chase, which is the cost. So this is actual data from WashU. So it's very interesting for me, moving from UVA to WashU. Barnes Jewish Hospital sends you these little sheets every quarter. So I didn't kind of crop this down so you can see this is real. This is the actual PDF that I've sent as a participating surgeon in thoracic. My name's up at the top, it's quarter 2, and it pretty much shows the operations. They put it here as the top 5 procedures that I do. And you can see I've highlighted in orange VATS lobectomy. My cost per case is about $1,800. We've started doing robotic assisted lobectomies as well. My cost is $1,000 more per case. Our outcomes, even we've now done about 150, our outcomes have been quite similar. So why would I even try and do this? Well, the answer for us is I'm still doing a significant number of thoracotomies. I do vasculobectomy for stage 1 lung cancer. I've not done it for more advanced stage lung cancer. For my own personal technical ability and my comfort level, if I have large hilar nodes or N2 disease, I've been more comfortable doing them open. I think I personally do a better job of the procedure. There are some thoracoscopic surgeons who can do a great job thoracoscopically. So at the end of the day, I think you need to do something well, something safely. And so one of the reasons I've been looking at robotic surgery is, can I do some of these procedures in a minimally invasive way that I've done open? So in conclusion, minimally invasive pulmonary resection has lower morbidity and mortality than thoracotomy. VATS and robotic procedures appear to have similar outcomes. And VATS pulmonary resection is less expensive than robotic surgery. So Dr. Reddy, I wish you the best of luck.
Thank you, Dr. Kozower. Thank you, Dr. Pollard, for the introduction, and thank you to the Society for the opportunity to talk. So I agree with everything that Benji just said. So I can't argue with any of that stuff, and I'll show you some data that we're generating. Disclosure, we are a teaching site for Intuitive Surgical, and I have spoken for them. Objectives really, or for me, is to review the differences between the VATS and robotic approaches, and then discuss the potential future benefits of robotic lobectomy. I think one of the things that we have to think about is where are we going to be in 10 years and where are we going to be in 20 years. And so for me, as a teaching site and as being part of a residency and a fellowship program, I think it's important that we're teaching this technology not as the only thing, but as part of everyone's armamentarium. So just like 30 years ago you had to learn laparoscopy, didn't mean you forgot how to do laparotomy for certain operations, but I think you have to be a skilled minimally invasive surgeon with both laparoscopic, thoracoscopic, and robotic skills. So I personally think robotics is just an extension of VATS technology. It's truly not robotic surgery. I know that's the term, but that's a misnomer. This robotic surgery is where you have automated procedures that are done. Here, this is telemanipulation of robotic arms, either by computer control or by a human through a computer control. So it's not an independent robot doing the operation. So just to clarify, currently we are still in a pretty beginning state in terms of technology. And so there is nothing that's really automated yet for any portion of the operation. 3D visualization, was kind of one of the hallmarks when this came out, but now there's a number of different systems that offer you 3D visualization just with normal laparoscopes, and you can wear goggles that'll give you a three-dimensional view in the operating room. Wristed instruments was one of the hallmarks early on. Now there's FlexDex is a potential competitor here, and you can see a picture where just using laparoscopic instruments, you can have the same kind of wristed motion that you have with the robotics. And so, again, I think there's this melding in terms of what's the current state of robotics and what's just minimally invasive, whether laparoscopic or thoracoscopic. Some pros about robotics versus VATS. I mean, at least in the current state, I think for robotics, you do have 3D visualization consistently. You have wristed instruments. They're smaller instruments. One of the things that is very nice, and for those of us who do a lot of it, is you have control of all 3 arms in the camera at once. For those of us who have medical students, and I'm in charge of medical students at the University of Michigan when they come through surgery, the thing I try and teach them is how to run the camera. Because if you have students or you have someone running the camera, it drives you crazy if that person's running the camera and you don't have control. One of the nice things about the robotics platform is that you control the camera. So you're not waiting for your 23-year-old medical student to go look up around the corner, look at, which if you're doing that every day can get very aggravating. So, so you have control of it. It's a complete ecosystem, which is also unique right now. What are the cons of it? It's definitely, I think, more expensive, at least in the current state. There's a question about, is it harder to learn? I don't know that it's harder to learn. One of the things is VATS technology has been around for 2 decades or more, and as Benji showed, still 40% or up to 40% of lobectomies are still being done open. I think there's been a greater adoption of minimally invasive with robotics. The con, though, also is the surgeon's not at the bedside. So if there is an emergency, you need to have some ability to control bleeding, especially for a chest case. For the foregut cases, I think it's less important. There's no haptic feedback, there's no touch. So everything that you're doing now is by visual cues. As you're getting around the pulmonary artery, the pulmonary vein, it's much more watching for visual cues in terms of looking for stress on the vessels. And there's still definitely a longer time, I think, for cases. And that probably adds also to the cost and the expense. There are a lot of similarities, though. This is one of the things we never talked about, is what are the similarities between thoracoscopic and robotics. There is no standardized port placement for either case. It depends on if you're a Dr. McKenna graduate or a Tommy D'Amico graduate in terms of where you put your port placement. Everyone's slightly different in terms of that. Same thing for robotics. There's 5,000 different ways right now that people are putting their ports. The incisions are always going to be smaller, and generally you're not making, for most people, they're making smaller incisions, not the mini thoracotomies. As Dr. Kozower showed, there's similar outcomes compared to the open approaches. I think there's definitely benefits that we're now seeing in terms of long-term pain being reduced with a minimally invasive approach. And the other thing is it's a much more challenging learning curve to do with minimally invasive, whether it's thoracoscopic or robotic lobectomies. And so I think that those are the things that we need to address, whether you're learning how to do it thoracoscopically or robotically. So I want to talk a little bit about the future state of robotics, because I think that's something that people don't understand. So there's up to 8 potential new systems coming out in the next 5 to 10 years from people like Medtronic, Johnson & Johnson, Titan, MedSnake, which is from Carnegie Mellon University. So just to show you here, this is the MedSnake product, which is an endoscopic robot that's coming out. It's been in the news, so this is taken directly from the Carnegie Mellon website. This is a picture of the Titan, which has been around for 20 years, but has not yet reached production, but it's supposed to be a single port. So there are a lot of new versions coming out. The one thing that's similar about all of these is none of them have haptic feedback. There are similar limitations to the Da Vinci system, but similar potential pros also with regards to that. So as I was saying, similar limitations, higher initial cost, lack of haptic feedback. There's going to be a newer learning curve for each one of these. One of the things, at least for some of the products that, if you're very good on the Da Vinci platform, we're hoping that there's going to be a cross-trainability towards some of these other platforms. But again, the surgeon is not necessarily at the bedside. So these are the same cons with all of these different systems. But these systems aren't going away. So I think we have to be familiar with them. And for our residents and our trainees, I think they have to come out being able to operate with these. So future state of robotics, I just put on here, this is a port site system for me for doing a foregut case. One of the things that I've shifted towards doing is eliminating the need for surgical assist. So if I'm doing a routine laparoscopic Nissen, I just need a surge tech at bedside. I don't need someone operating the camera. I don't need someone retracting because I can do the whole thing by myself. So that's, I think, ultimately going to be the future state in terms of any sort of operation. So all I need is someone who can pass or remove sutures, really. Now for at least the Da Vinci platform, there's a suction for both the SI and the XI. So even in terms of suctioning here and there, you have a suction available. I think in the future, they're going to be able to automate parts of the operation. So, we see all this stuff about automated cars, and, you have cars that can parallel park. Well, if you have cars that can parallel park, why can't you have a robot that can actually get around a pulmonary vein and ligate it, or sew up the cruise together for a hiatal hernia? So I do believe that that's coming. There's work being done on that right now. So for a lobectomy, right now, again, my setup is I have an assistant list or port placement, so I have 4 ports where I don't have a 5th port. I don't have an assistant there in their own independent port. So this is the harder one, I think, to make a case of not needing someone at bedside. I always have someone at bedside who can hold pressure on the PA, but ultimately, as technology gets better, you may or may not need that depending on what your how you manage those crises. And again, there are going to be automated parts, I think, even for a lobectomy in the future, within 10 or 15 years. So you can outline where is the pulmonary artery, where is the pulmonary vein, and can the robot automatically get around there and staple that? And is that going to be safer? I mean, is it safer for a robot or your car to drive itself than for us to drive? It depends on who's driving. And so my parents would have arguments with that, but I mean, so I think the same thing's going to happen here in the next 10 to 15 years. So a couple of things just to talk about, some of the things that, to address some of Benji's talks and talks about cost. So this was from one of our fellows who presented this as a poster at the General Thoracic Club, and Here we reviewed our first 100 minimally invasive lobectomies when we were starting our robotics program. This is from a couple of years ago. And we looked at 75 thoracoscopic lobectomies compared to 25 robotic lobectomies done in the same time period. And we looked at outcomes and costs. This is the only slide I'm going to show you, and I apologize, it's a little blurrier than I'd hoped. This is basically showing in red the robotics, and this is the different costs in terms of OR direct costs, variable costs, combining those two. So this last one basically just confirmed that robotics costs more, and I'm not arguing that. But this is our first set, and robotics was not double the cost of our VATS cases. Actually, when you looked at it, it was only about a 20% higher cost in the first 25 lobectomies. And that's in our hands, and those of us, myself and Jules Lind, were doing the majority of those, were experienced thoracoscopic surgeons already. So I don't think there was as big a transition, but it wasn't a huge cost, at least in our development. It took a longer time to do the robotic cases, 48 minutes on average, with no improvement in terms of speed or experience over the study period. Even when we look now at our more recent data, we have not increased the speed of our cases, but one of the reasons for that is our fellows do the cases. So our fellows are operating, and so if our fellows are doing it, I can't get it under 2.5 to 3 hours. If I'm having them do a portion of it with me controlling it, but still with them doing it. So if I'm doing it on my own, I can do it in probably about 1.5 to 2 hours consistently. But in our institution and the way we practice, we have new fellows every year and new residents every year. So one of the other things that we looked at was the pain score and satisfaction score, and that did not significantly differ between the groups. And so at least in terms of long-term outcomes, it was similar. This is a data set where this is being published right now, and so I'm not going to go into depth on this. And when I presented some of our data from the Premier database at the General Thoracic Club, actually Dr. McKenna asked about a comparison, if you remember, all the surgeons, and not just the high-volume surgeons. So here we have a propensity match analysis of a Premier database and looking at 3,000 VATS versus robotic lobectomies done by surgeons of whatever volume. And so the data in that, and this manuscript will be coming out soon though, is favored robotics very slightly in terms of conversion rate, complication rates, and length of service. So that manuscript's coming out. This has been presented, so I wanted to show, taking off of that data, so in that previous study we just looked at all comers in the Premier database over a 15-year period looking at thoracoscopic versus robotic lobectomies. One of the concerns I always have is looking at the high volume surgeons. So we always talk about looking at low volume surgeons. Is the learning curve there? Are people adopting robotics, and are their results going to be as good? So what we took is we took that same database and we focused only on surgeons who were doing greater than 20 lobectomies by robotics or by VATS per year. So that's a fairly high volume. We figured those people are beyond the learning curve, and we wanted to compare the results of those expert surgeons. And so what we did is we had a propensity mass analysis, again comparing about almost 1,200 cases, and this was performed by 65 robotic surgeons and 81 VATS surgeons in the Premier database, which represents about 700 hospitals. Even in that experienced cohort, the robotic cases took a little bit longer, 24 minutes on average. That was statistically significant. The conversion rate was lower in the robotic cases, 4.7 versus 7.7%. I think Dr. McKenna's data of 2.5% conversion rate is outstanding, but it's also hard to replicate. And so this is looking at high volume surgeons doing more than 20 cases a year. Thoracoscopically, the conversion rate is still 7.7%. Slightly lower 30-day complication rate in robotic cases, 33 versus 38%. Again, this is an administrative database. This is not a surgeon-driven database. So the data is not going to look exactly the same, and is it going to be as comparable as some of the surgeon-led database or the STS data? I'm not sure. So limitations, as I said, administrative database. One of the things that we talked about, and we're putting in our manuscript, is the VATS conversion rate is higher. And one of the things I can't account for is whether or not thoracoscopic surgeons put the camera in and have a lower threshold for putting the camera in and then converting to open for cases that may be metastatic. And so with a robot, I don't think you're as willing to do that because of the setup and the costs associated with that. But with a thoracoscopic approach, it's just having the camera open. So does that count as a conversion? We don't think so, but having said that, I think there's some room for error, and that may explain some of the differences in conversion rates. So in conclusion, I think robotics and VATS do have better outcomes than open surgery, as Dr. Kozower alluded to. I think robotics can be the equal of VATS, and I think there's a question about whether or not, looking at experienced surgeons, whether or not robotics may be better than VATS or the equivalent. There is some data coming out that we're looking at that from the other administrative database that increased volume in robotic cases reduces cost, and that's approaching some of the thoracoscopic costs, and again, in a large database series. I think the real question is, does the lower complication rate and conversion to open rate negate the higher costs, in that 5 to 10 or 20%? And I don't know that anyone has that answer yet, but I think that's the next question to look at, if that's truly a benefit. So, thank you. I think we'll have